you for coming to the epidemiology seminar Fridays. I have the pleasure of introducing Dr. Carroll. She's an epidemiologist and certified tobacco treatment specialist addressing commercial tobacco use disparities, particularly among American Indian populations. Reflecting the needs of her community partners, tribes, clinics, and nonprofits, the methodologies that she applies span from secondary data analyses to qualitative research and clinical trials. She has nearly 50 peer-reviewed publications that include describing the co-development and evaluation of digital smoking cessation interventions for American Indian persons, the tobacco industry's marketing tactics aimed at American Indian persons and other minoritized populations, and perceptions of various existing and novel smoking cessation approaches among American Indian persons. Also, she contributes through epidemiology and clinical trials to the evidence base on potential cigarette product standards, such as reducing levels of nicotine and limiting the level of filter ventilation, an area which she views as another avenue for reducing commercial tobacco use disparities. In her community-engaged research, she devotes considerable effort to ensuring that the results of her research do not just land in scientific journals, but also shared with research participants and community partners via community-facing reports and infographics. In 2023, her contributions to co-creating smoking cessation resources for American Indian persons were highlighted by the White House as part of the Biden-Harris administration's cancer moonshot agenda to end cancer. Dr. Carroll's research has been supported through her receipt of multiple NIH grants, including a KO1, R21, and R13, and a contract. A great source of support and inspiration for her research stems from her community partners who are unwavering in their efforts to restore the health and cultures of American Indian persons. And I have also the pleasure of giving you this nice high class for presenting to us today. So help me by welcoming Dr. Carroll.
Well, that was the Cliff Note version of what you're going to hear today. So thank you for providing such a great introduction and overview of my work. I'm thrilled to be here and to share with you guys. As many of you probably know and as alluded to, I'm over in the Division of Environmental Health Sciences. As an epidemiologist that does a lot of community-based work, I feel kind of at home with this division and all the work that you folks do. So I'm just thrilled to be here. So as mentioned, I've received some funding from NIH. I want to start off though by just taking a pause and reflecting on this photo. And so what I often share with folks outside of Minnesota is that Minnesota is where the water reflects the clouds. And in Minneapolis, where we are now, where we work, is a sacred site to many of our American Indian people in the states and homelands of the Dakota people. And so my work and my research with community, I often reflect on my positionality as a white woman in academia. I think a lot about the resources that I am privileged to access, the work that I get to do, and how I can really give back and help build up these relationships that have been justifiably torn apart and due to prior experiences with academia. So I'm going to give you just an overall of what I've been up to. I think some of you might know me a little more than others, but I'll just share on some of the different areas that I've been focusing. You'll hear a lot about my work around smoking cessation interventions that I've co-developed with American Indian people. I also am starting to venture out to doing work more broadly with the rural population, and so I'll share a bit about that. And then last, a big part of the work that I also do is around cigarette product standards. So the FDA, Center for Tobacco Products, regulates tobacco products, which is kind of like an interesting thing to think about. But essentially, they can implement product standards in tobacco products if there is an evidence base to show that it will benefit public health. And so I've been fortunate to contribute to that evidence base on some various cigarette product standards that I'll share with you today. So before I jump into my work, what I'd like to do is share a little bit about how I kind of view the world and the work that I do. And so I'm sure many of you are familiar with this framework. If you apply to NIMHD for any funding, you have to show how your research aligns with this. And to me, what it really does is it tries to force me out of just focusing on that behavioral or individual level of influence and thinking more along the lines of multi-level interventions to really make a bigger impact on the health disparities that we have today. Another framework that is quite busy is one that really looks at cross-cutting constructs around what it means to be community engaged or CDPR. And I'm not going to dive too far into it, but one area that you for sure can't see that well is a box up here that talks about outcomes beyond the research. So I think we're trained to really look at outcomes related to our intervention. So for example, if I'm doing a smoking cessation intervention, naturally I would look at smoking cessation related outcomes. But I often think about how is this research impacting the community? What capacity is just doing this research building in that community? How is my impact on this community advancing the relationship with the University of Minnesota? And these communities. And so again, really thinking outside of traditional outcomes and more about the context that we get to work in and build up our community partners. One thing I told a longstanding community partner that I have at the American Indian Cancer Foundation is the day that they move forward on R01s and R21s without me is going to be a good day. I'm able to come alongside and aid them and assist them, but really developing the capacity for that organization to move forward with their own agenda. Okay, so I want to first, as I dive into this area, I'm going to talk about two main buckets. And one is going to be a tribal smoking cessation program that I co-developed with a colleague, Dylan Jennings. And then I'm going to talk to you about some of the digital smoking cessation interventions that are going to come out of that effort. But before I dive in, especially when there's ever, even an audience of folks in the commercial tobacco prevention and control space, certainly when folks are not inundated with that area of research, I like to take a pause and reflect on this photo and how beautiful and green and much life is in this photo. So this is a photo of nicotine rustica or traditional tobacco. And not all, but many American Indian tribes have a strong tie to tobacco. It is used to connect with the creator and used in offerings to show respect to an elder or a community member. And this is very different than the commercial use of tobacco that we know is developed to get people addicted and to be lifelong users until many of them end up dying. And so what you'll hear about in my work is this idea around leveraging this beautiful cultural asset and strength and helping American Indian people get back to this cultural practice that has been unfortunately lost due to US colonization efforts that included genocide, forced boarding school on American Indian children to wipe away their American Indian culture that included the use of traditional tobacco and traditional tobacco protocols around harvesting and growing and the stories that go with that. And so there's a big yearning to connect with tobacco. And when commercial tobacco is more accessible, that can cause an additional layer of enhanced addiction in this particular community. And so again, we'll be talking about reducing commercial tobacco, and a big part of my work is also reclaiming traditional tobacco within these communities. So as mentioned, I am an epidemiologist and do a lot more intervention work these days, but I often use epidemiology to help identify how we can better serve community, and also as like preliminary data for a lot of my grants to show the need and the rationale for the work. And so this graph essentially shows the odds of lifetime quitting. So if you take ever smokers and then look at the proportion who are now former smoking, right? Just a really kind of snapshot picture of the populations. And we see that there are populations that have been left behind when we compare to other more socially privileged populations. And the one population, well, two here that you see that have been left behind are American Indian, Alaska Native population, as well as Black and African American population with regard to success in quitting smoking. And so this has largely driven a lot of the work that I do.
Sorry, can I ask a quick question?
Sure.
Is that data you just showed us, does that include vaping?
No.
Okay.
Yep, this is looking at smoking. Yep, yeah, so we can talk about vaping. I have some thoughts on vaping that I can. Okay, so this is, as I alluded to, I actually, with Dylan, we applied for one of the Program in Health Disparities research grants. And it was interesting because this was also co-funded through the Cancer Center. And Dylan is in a tribe in Wisconsin. And so I had to make the case for why we need to fund work outside of Minnesota. And the Cancer Center was really open to that. So I just want to share that not everything is, there's this sometimes a gray area where you can really advocate. And what ultimately we said was the work that we're going to do here within a Ojibwe tribe will, really transcend to what we know and can do with other communities in Minnesota. So this is Dylan, and we've been working together for over 5 years now. This is actually a photo of Dylan and I and some other community members out at his tribe, where we were taking traditional tobacco mixtures and making those mixtures together for really the whole process of connecting with tobacco and reclaiming traditional tobacco. And so Dylan really envisioned wanting to develop a quit smoking program for his tribe. He's a prior tribal councilman, but now just really a leader, a health leader in his community and really trusted. And he came to me and said, I want a program that focuses on rebuilding traditional tobacco at its core. And as part of that, we can use that to motivate folks to get off commercial smoking cessation. And so it was a really exciting opportunity. I said, of course, I'll come alongside, and you can really lead up the efforts to determine kind of what the curriculum would look like or the programming for the traditional tobacco component. And I'll come alongside with the approaches to quitting smoking. So what we ended up doing is we had 2 guidebooks. The one on your left is a guidebook that really gets at, Dylan essentially went to elders and knowledge holders in the community and asked them to orally share. He got permission to write because in many American Indian communities, things can be orally shared, but not always written. Stories about traditional tobacco and its origin and how it's supposed to be used and some of the stories from that community. And so that is a book that actually is not shared outside of that tribe. And then this book on your left, it actually was initially a book that was developed in the 1990s for California tribes and now is included. If you go to the NCI's website, they have like a whole evidence-based repository. And we took that and we updated it. So back in the 1990s, some things were not around like they are today. For example, like nicotine replacement therapy that can improve smoking cessation chances by as much as 50 to 60%. So we layered that in there. We also encourage this 2-eyed seeing approach where it's both this Western and Indigenous ways of knowing together. So seek out nicotine medications that can help you quit, but also seek out your traditional or spiritual healer in your community, whether that's an elder or somebody that has that official title to help you with your quit journey. And then we further, as you can see, updated these both. We hired a native artist from the tribe to develop the imagery. And for the particular tribe in Wisconsin, floral imagery, as you see here, is often used in a lot of their branding of tribal infographics. And so we kept with that theme, and it's just been some beautiful artwork. And that artist continues to work with me on various dissemination outputs that I create. So as I mentioned, this 2-eyed seeing approach, this has really become a huge cornerstone of a lot of the work that I do with American Indian communities. But I think it can also apply to really any community you work with. This idea of leveraging and integrating community knowledge or cultural strengths and ways of knowing along with more Western-based approaches. And together, that holistic approach and applied to interventions to improve health can potentially be really promising. So without going back to that NIMHD model, What I want to share is we piloted this program at the tribe. And it's actually really exciting. After that grant, they continue to implement the program, which is like the ideal that you want, is that the community will continue to invest in a program and find those resources. And Dylan continues to lead a lot of the sessions. From piloting though, we learned that like any in-person program or even coming here today, people can have a challenge getting to an in-person program. And so participants suggested that, what if, of course, we get to go home with these booklets, but more digital forms for people that can't attend as well, and maybe integrating this into like an app or a text-based program. And we thought, wow, that's a really good idea. So we started to move toward this area. And, certainly, why did we do this? I think this is a true like community-led suggestion. There was interest in this approach from the community. There's high smartphone ownership, pretty much. If you look at some of the most recent surveys, even if you look at like rural populations, like 85 or 87% of the population uses smartphones. And in a lot of communities, smartphones might be like the main way that folks engage with like health-related material, news of any kind. And so this is, of course, not 100%, and there are some differences between, more urban populations or American Indian and rural. But overall, we thought that this would be a really good angle for those who have issues with traveling in person. And just thinking about, too, when we think about that model in that community level of domain, reduced healthcare encounters are common for many of our socially underprivileged or minoritized populations for various reasons. And if we're requiring people to come to healthcare to get smoking cessation treatment, that is that can be a barrier. So overcoming that with developing these digital resources to reach people where they're at, wherever they're at, and whenever they're at is how we were viewing it. Certainly, this was not a novel idea. There has been some like really robust systematic reviews showing that digital, specifically digital smoking cessation interventions can be effective over like the handouts that we had used. And so there was some evidence-based around internet-based intervention and text-based interventions. At the time, and I think this is probably still true, is apps have really, takes a while for a systematic review to be done, for the evidence to accumulate. And so the evidence base was inadequate, largely because of just the lack of studies at the time. But we thought, oh, okay, that's more rationale for us to move forward with an app. And this is a photo of Wyatt Pickner. He's at the American Indian Cancer Foundation, and folks in here might know who he is. He's a great friend and colleague of mine. In fact, we just were in Scotland for a conference together, which was really fun. And we were the ones that really kind of ran with this idea of digital smoking cessation resources. So we knew this was a good idea because our community partner told us that it was a good idea, but we had to prove to NIH and our funder that this was a good idea beyond just saying that, this was informed by the community. So what was the evidence around this? Well, as I mentioned, our effort with the tribe in Wisconsin, that pilot data was pretty nice to show in the grant application, but we also looked at some other prior studies. So these are two of the published studies that have looked at specifically the angle of culturally aligning or culturally, targeting, whatever word. I like to use the word align because of the nature of targeting, especially within the tobacco industry targeting world. So culturally aligning a smoking cessation intervention, like what is the promise for that among American Indian peoples? And both of these trials had a non-statistically significant difference. However, what really drove that was there were the loss of follow-up over the trials sessions, and transportation was cited as a #1 reason. We're like, this is amazing, more preliminary evidence for us. And so our whole approach was that we conveyed to NIH was, can we improve or maximize as much as we can smoking cessation outcomes for American Indian peoples if digital resources are culturally aligned? And that is a big kind of rationale of what we've been doing. I've already shared on that. So what we also recognize, Wyatt and I and Dylan and some others, we looked at each other and none of us were app developers, right? We weren't even going to try and pull that off. And so we thought, okay, while ultimately we one day would like a more like a grassroots roundup project, an app developed, what existing apps are out there that we can leverage and really say that we're bringing expertise in culturally aligning to the grant to develop. And so this is the National Cancer Institute Smoke-Free Institute, and it's, developed over time, but essentially what it is a website that you can go to and get help and support with quitting smoking. And so a lot of this is creating a quit plan, identifying your smoking triggers so that you can create a plan to avoid or mitigate them. Talks a lot about nicotine replacement therapy and medications proven to help folks quit. It also refers to additional resources like the quit lines that not a lot of people use, but also what is becoming more and more popular are apps and text-based programs to help people be mindful on their quit journey and to support quitting smoking. So we thought, wow, we should just take the app that they've developed and was just for the general audience of people who smoke and culturally align this for American Indian communities. So we applied and received some NIH funding, and here is a photo of us. You'll see your very own Rachel on the screen. And I think this was taken like weeks into the pandemic, and we didn't really think about it when we submitted it, but essentially the whole trial and the whole efforts were able to be done remotely. So, using an app, you can enroll people from a community or a region, and you can randomize them to an app, and you really do not have to have an in-person visit. And so that kind of just really bode well with all of the shutdowns that were happening with the pandemic. And, I think too, it's important at this time, I was working with a couple of different communities, and reactions to COVID-19 resulted, rightfully so, in some communities saying, look, we need to focus on this. This is, where we're at. We're just trying to get our hands on this pandemic and make sure that our community members are vaccinated. Whereas I had conversations with Dylan and some others, and they thought, okay, we can really find a way to make this work. Smoking cessation now more than ever is probably going to be really important because of the impacts of the pandemic. And so we just moved forward. The photo on your left is the Quit Guide app, the one that we took, and we essentially tailored, and I'll share a little bit about what that looked like. So it was not rocket science. We essentially took the app and worked a lot with Rachel and others to think about, what type of questions should we ask so that we can essentially get fruitful data on how to update this app to better address the culture and needs of American Indian peoples. And so this was actually published, well, it says 2024, but it's been out for a while now. I'm just going to jump to some of the summary of recommendations. And I will say too, with this app, we were working predominantly with two communities that largely use traditional tobacco. And that's not the case for all of our American Indian communities. And so we'll kind of talk about how we have thought about this idea of creating a program that's supposed to be salient and address the needs of people that have such diversity in cultures and unique relationships with traditional tobacco. So the summary of recommendations that we got from our participants are here. We essentially interviewed 40 American Indian people in largely the Midwest region, which was largely Minnesota and Wisconsin because of where our community partners were located at. And we asked them, take a look at the list in the app that you can use to indicate your smoking triggers, right? Because one of the ways to, as I mentioned, to really help people on their quitting journey is to be thoughtful about their triggers and create a plan. And there were a lot of triggers that came up that were not previously in the app that we have since integrated. So one is really not having access to traditional tobacco and using commercial tobacco in its place. We also really heard from a lot of participants that grief and experiencing loss was a major smoking trigger. And so being able to be thoughtful about that and help them with that as part of the quit journey came up a lot. And then, of course, you see some other bucket areas that we got feedback on. A big area that prevailed was really the reliance on community and family and elders to help with healthy behavioral change. And so we thought about, how can we integrate these components into an app? And I'll show you in a couple of pages how we did that. As I mentioned, or maybe Amanda mentioned, one of the things I love to do is not just let our results land in a scientific journal that has a paywall. And so this is an infographic that developed from that work. And one of the things you'll see too is how everything is really asset-based. So how can we promote quitting, right? And so even though we got a lot of feedback about barriers, we switched that around to be a positive framework in this infographic. And there's a QR code if you're savvy to download it. The other thing that we did is we looked in the literature, and there is, SAMHSA has a curriculum that is used by some communities called the Gathering of Native Americans. And the goal is to, it's an asset-based approach and strength-based approach to substance use prevention and reduction. And what it does is it relies on some, beautiful indigenous worldviews of belonging, creating a sense of belonging in the group, mastery, interdependence, and generosity. And so I'll share a slide actually next on how we try to align our content and look at, this tailored content that we're introducing. What worldviews in the Gathering of Native Americans does it align with? So just in brief, what we did is we did add, as I mentioned, some education on and preparing for triggers that were more common in these communities than others. And that's really helping people with the mastery of getting, to developing their tools and skill set to overcome. We also integrated some pages on encouraging folks to connect with one's culture, to reach out to folks in their community as the process of helping to heal from grief and loss, and creating really the sense of belonging in the app. And just for the sake of time, I'll skip forward. Another thing that we did that I thought was just really beautiful is a lot of the wordage in the prior app and materials was quit smoking for yourself. You can do it. And really it's this idea of quit smoking for your family and your community. And the idea that if you quit smoking today, you can really be there longer for your loved ones, and really getting that generosity and giving back. And so we integrated that too. And then here are some photos of the culturally aligned version. That's actually my daughter in the app, so no HIPAA issues there. And so we integrated new app pages. We updated the Quittism library with tips and for quitting and reference to cultural strengths like rely on creator for quitting smoking. And so ultimately what it was the same program that was then expanded with some tailored content. So actually just this past winter, we finished the small pilot randomized controlled trial. And so essentially we recruited American Indian peoples from the Midwest who were smoking and interested in quitting. And we did this all through remote procedures, and essentially had them use either our tailored version or our standard version. And then we followed them over time and did a saliva sample as well to confirm their smoking status. So these are piloty, but exciting. So we collected several different measures, and one of the measures that we did was on, this very common acceptability measure. So would you recommend this app to a friend? Which we did see higher endorsement of that in the tailored version. We also asked about fit with culture, and so a better indication that we did do what we were hoping to do. And I will say there was several cultural fit measures that all showed similar findings. And then We also found a doubling of the abstinence, although not statistically significant, but telling that to our community partners, the excitement of knowing that this app could double the quit rate, or a signal that it could, was really exciting. And so, as you can imagine, this is our pilot data for our next round of the grant, which would be larger efficacy testing that's under review. So we were doing that, and we're working on the app, and NCI actually reached out to us and said, okay, the app's great, but we're really interested in the text-based programs that we have. They just have longer, text-based programs, you're texting versus an app that can get clunky over time and needs to be updated to keep up with the more savvy apps. And of course, there was more evidence-based for text-based programs. And so they asked us to come on board and to apply what we did in the R21 to their text-based program. And so just because of time, I'm not going to dive too far into the text-based program. Essentially, it's depending on when you start it, 6 to 8 week program. It's really intended for people interested in quitting. And there's a lot of text at the beginning around your quit date, and then they kind of fall off with over time. So this was a contract which you learn a lot about working with the government via a contract. There were fruits and challenges, I'll summarize it that way. But what we decided, we came together with really these four agreed upon goals. We were gonna culturally align it based on our learnings. We're gonna integrate some of what we know is what works for people to quit smoking. So really maintaining that core infrastructure. And then really at the end of the day, this will be an accessible program. And when American Indian people go to the MCI website, they see a program developed with them in mind. And so I just wanted to share a couple of the texts and how we tailored those. And so the maroon buckets are those gathering of Native American worldviews that we aligned with. And we actually would start to see, are we doing more belonging than mastery? And we tried to have similar frequency in the program. I will say this program was it's like 300 texts long, and Wyatt and I sat one day and went text by text by text. And he always jokes with me, he had to ask for a bathroom break, he's like, can we take a pause so we could come up for air? And so we just really spent a lot of time over these original texts and updating it to be more culturally aligned. One of the things you see in that first one is really the sense of belonging we tried to infuse. And what we tried to do was make it clear that there were a group of people behind this program that had developed this for that person. That yes, it's automated, but we're really here to champion you on, you belong here. And that theme actually came up in our audience testing as one of the reasons why our participants liked this program. I'll also share that there are some initial keywords in the program that does allow for some on-demand support. So if somebody's having a really strong craving, they can text crave and get a tip back on how to mitigate that. Maybe it's call a loved one, go for a walk, get some gum in your mouth. There's also mood and slip. So we kept those, but then we added some what we consider culturally aligned keywords. Mine, really, it's about balancing and recentering yourself. So a lot of that is on mindfulness and reflecting. And as I've really learned from some of my colleagues and who are elders, mindfulness has always been an indigenous approach. We also integrated honor. So this is where you can text and learn about different American Indian cultures. And so what we actually did is we asked through the American Indian Cancer Foundation listserv what people refer to tobacco in their own language. So Asema, Ojibwe, and really so that people could learn about their traditional tobacco word. And then connect is just reinforcing the idea of connecting with family and community and encouraging people to do that in different ways. So we also recognize that we are trying to develop a program that is inclusive for as many American Indian communities and cultures as possible. And how do we do that in a way that is not stereotyping, is not just assuming that there's this one culture, when we know there's richness and diversity and beauty in all of these cultures. So we got a community advisory board together, and I always reflect on how this was in January in Minnesota that we were able to have people come here, which just shows you the commitment of this group, because I think it was like freezing that day. And we had our community advisory board just really pour over different examples of text messages and content in the program and provide us feedback, really with a goal toward making sure there was, no stereotyping, it's as inclusive as possible. There was a suggestion to include some more humor-based tips to really, make participants kind of recognize that, this is hard, but, give yourself grace. So one of the tips that we actually integrate into Crave that I just think is so funny is smoked salmon, not cigarettes. So things like that. And the other thing we learned from our CAB was to shorten our statements as much as possible. Just brief, short statements. Don't have somebody do 3 different things to mitigate a craving. Give them one, because as we all know, having all these options can be a bit overwhelming. And so it was really just a fun time to get together and learn from one another. We then did some very brief audience testing. This was actually one of the quickest initiatives that I've helped kind of co-lead. From the beginning of the contract to its launching was a year. And so at this point, we were in like the last quarter. And essentially, each of these rounds had about 10 people represented in them. And we got really positive feedback on the program with some suggestions on making sure our wording was not blaming the person for smoking, but really encouraging them to keep trying to quit. So this program is now available on the National Cancer Institute's website. And I presented on this just a month ago now. And at the time of launching, just within a few months, we had almost 250 people that really were signed up and had set a quit date. So they were in the program. And I just think about how exciting it is to think that this program could help, one person quit and live longer for their family and community, and knowing that we have hit so many more people with this program. And so it will really be exciting to see how this unfolds in the future. As mentioned by Amanda, this effort was cited as part of the Cancer Moonshot agenda. And I always laugh a little bit inside because I shared this with my mom. And of course, my name's not here. So she's like, how do you know they're referring to you and Wyatt in this? And because, it's a school of public health American. And I'm like, Mom, we know, but we don't know. So maybe it's not. So we'll, to be determined. But I also say that all of this work that in the highlight here reflects all the efforts that communities have been doing to really align and infuse their culture and programming. And the privilege that I had to get to use that and learn from that knowledge and work with the American Indian Cancer Foundation to make a program that's accessible for those who are interested in it. Okay, so I know I don't have too much time, but what I wanted to share a little bit about some of the initiatives and just a couple slides on how I'm thinking about a future area of study or grant on smoking cessation with the rural population. And so again, this is actually a framework that my colleague developed. I should have her name on here, Olivia Wiskowski at Rutgers. We were looking at the NIMHD framework and thinking about barriers to quitting smoking for rural people and the culture around smoking, as well as the many social determinants of health. And one big area that falls really within that community healthcare domain is reduced healthcare encounters. And then so once you have reduced healthcare encounters, you have reduced treatment for smoking cessation, reduced awareness of treatment for smoking cessation. And when there is, when that is not at the table for rural people at similar levels of urban people, that can create some of the disparities and challenges with quitting smoking. So these like yellow bucket areas and actually the green are kind of the areas we're honing in on a multi-level intervention. But for brief, I just wanted to share how we're going about that. So one of the things that, not rocket science, what I love to do is to go to the community or the target audience and just really ask them, what is it? What are the barriers? What are ways we can increase this or create a solution? So we did a elicitation survey, which actually is set up to be a survey like you would take on Red Cap, like a quantitative survey. But you actually ask people for short responses. And so it's kind of like a qualitative, quantitative survey. It can kind of confuse reviewers if you don't provide examples, as I've learned. But essentially we ask them, we want many questions. I'm just showing you a couple of these. So what would make it easier for you to use, nicotine patches, gum? And I had a student put these into word clouds to really visualize it. We're going to see if this goes well with a journal, to be determined, but I think we actually created the font size based on the number of times it was mentioned to emphasize, but at least it's good for a presentation. So what you see there is, wow, it is obvious that cost of nicotine replacement therapy is a major barrier. And then right below that, more availability or access came through. Not shocking, but just great to kind of see that being voiced in our population. And then, as you see on the right, when we ask them about disadvantages, there is this perception that nicotine replacement therapy is another addiction, that it's a clutch, it is not breaking free, it's not the ideal. And so this is among pretty much all people who smoke. I think there's also, we've shown in a paper, widespread misperceptions about nicotine that I think are funneling into this. So nicotine is not what is responsible for the mortality and morbidity that comes from tobacco. It's responsible for the use of that product and the addiction to that product, but it's all the other components in specifically the combustible product or the vaping product that can cause the harm. And so that is a hard concept to get around because, well, if you use a product more because of nicotine, it's more harmful, right? But with nicotine replacement therapy, these are safe and approved by the FDA for quitting smoking. And so we really are thinking about, on the left, these environmental barriers, but on the right, these individual perception and barriers that might be overcome with like education or some type of health communication. And certainly that's not the whole picture, but those are two that we're going to be focusing on, as I mentioned, and shown here. So this work, I'm really excited about starting on. If you have interest in rural populations or have any thoughts or ideas, please send them my way, or we can talk after. Okay, the last thing that I'm going to talk about is the body of work that I kind of say I grew up in. So I did a postdoc here for two and a half years with Dorothy Hatsukami. And she's really the one who taught me like clinical trials, intervention research. She got a lot of her training herself from being a site for pharmaceutical companies looking at nicotine replacement therapy testing. So one big area, as I mentioned, that we can think about, as I've mentioned, everything's either been on really trying to get the person to quit through behavioral change or overcoming barriers. But what if we take the cigarette itself and make it less appealing, less toxic, or less palatable? And this is an avenue that has now been granted since 2009 when Obama signed into law the Family Smoking Prevention and Tobacco Control Act. But essentially this means that the FDA can regulate tobacco products. It's a bit different than medicinal. So when you try to get like a medication approved, you have to show that it's a benefit to the individual, weighing the benefits and the side effects or the adverse outcomes. With cigarettes, it has to be a benefit to the population as a whole, like a public health standard. And what that really means is not clear to everybody, but essentially what you can show is through science, if a product standard can either reduce initiation of the product or improve cessation, quitting of the product, or get people to lower their harm. So that's where we could talk about e-cigarettes later. But one big area of the cigarette and why it's so good at doing what it does is because it's really a beautiful, in a bad way, delivery system of nicotine. The industry has perfected this device to deliver nicotine faster than any other product. This is also why I coach people that when you know you're going to have a smoking trigger, maybe you're getting in your car or you're going to go have a cup of coffee, like very common smoking triggers, you need to pop that nicotine gum or lozenge 10 minutes before, because it takes so much longer, right, to hit the nicotine receptors. So nicotine is what causes addiction to the products that then can cause the detrimental disease. And I've been researching this area of a nicotine reduction standard. So simply lowering the levels of nicotine in cigarettes so low that people cannot actually even compensate. So that's always a concern. Well, aren't people going to smoke more? There's just not enough nicotine to even smoke to get enough. And why not just lower to zero? Well, the Tobacco Control Act was agreed upon as long as nicotine was not lowered to zero. So the industry was very, lobbyists getting a policy through, because we know there's compromises that have to be made, and that was one. So I'm, with this timeline, gonna catch you up on all the work. So the first question you might ask, well, how low? And this was a study done that was published in New England Journal of Medicine in 2015 that shows that actually if we lower nicotine, of course we can't lower it to zero, but if we lower it to 95% or lower, that reduces dependence, it increases quit attempts, and it reduces cigarettes smoked. Then after that, and I will say there's other studies, right? These are just kind of the landmark ones. After that, the question was, okay, do we gradually reduce people's nicotine over time, or do we immediately do it? Like in theory, January 1, all cigarettes available would have very low nicotine. And that study was just recently completed right when I started my postdoc. And what was found that if you gradually reduce, there is a period of time where there is enough nicotine in those cigarettes to compensate. And so toxicant levels will increase. And so that we do not want population level. So immediately reducing nicotine in cigarettes was the ideal. However, as you would expect, there was a peak in withdrawal symptoms, uncomfortability in the whole study around 2 weeks. So the question is, what's the next study? All of these studies were really confined to people just being told to smoke a cigarette or that's low or normal. The world does not just have cigarettes, right? We have e-cigarettes, we have nicotine pouches now, there's synthetic, there's always a new product. So the most recent study that was completed in 2020, it's hopefully going to be published here soon, it's under review, basically tried to mimic the real world as much as possible. And the question was, if we have access to all these other products, will reducing nicotine levels in cigarettes indeed continue as we would expect, which would be increased smoking quit attempts. The big issue was dual use. Are people just going to dual use and maintain? So these are still questions that were answered by this study. And ultimately, the results again were positive. This study also, I think, flips a question that we commonly get asked, like, why not just educate people about tobacco products, the relative risks, and let the market dictate where consumers go? You can't let a market dictate consumers when you have a highly addictive product on the marketplace, right? So this study shows that even if people have access to products and are informed about the relative risks, you need a nicotine standard to really accelerate quitting smoking. So my area that I've contributed to is really asking questions within more like a health equity lens. So I've been asking, do the benefits that we see in the trial hold true for the various populations that we've been able to recruit? So for example, a big group that I focus on is lower versus higher educational attainment. We know that those groups, lower educational groups, can have more social influences to smoke, reduce healthcare encounters, and so forth. Does a nicotine standard seem as beneficial? And the answer so far has been yes. So we see similar benefits across groups, but that does not mean we can't maximize the benefits in the groups that have been left behind in tobacco control. So a whole area that I've been trying to push is that our populations that are already experiencing disparities, this is an opportunity for us to really rally around them, give them the cessation support that they can so we can maximize cessation during this time. And one of the last slides I'll leave you with is a group I've been working with on modeling. The very smart group out of Michigan, but essentially they take data points from clinical trials and like quitting and the status quo in the real world and estimate the benefit of a nicotine reduction standard. What this graph shows in the gray bar is estimates from the recent census data on the proportion of each population in the United States. And the maroon is the proportion of the overall deaths that will be averted by this standard that each of these populations represents. And the reason that you see more represented in the American Indian and the Black population is because their quit rate in these populations is already so low. They've been left behind. So the standard can accelerate quitting the proportion in these groups, which is a really exciting data point to drive home. Okay, I'm gonna finish here. I do have a dissemination website where I, direct people to. I get some, emails and things about accessing some of the programs or resources or findings, and so they can be found here. I also reflect on my community partners and these three guys here that have really been unwavering in their commitments to their communities. I work closely with each of them. Dylan and I actually, we have a call this afternoon. He's also getting his PhD. He's like one of those just remarkable people. And so it'll be exciting for him to continue to be a thought leader in this space. And then of course, this work reflects a lot of people, not just myself. And then the last slide I'm going to leave you with is I've had the opportunity to be part of a steering committee with the American Indian Cancer Foundation and other groups. We held this conference actually here in Minneapolis 2 years ago, which is hard to believe. And it's going to be here again in June. And this is an opportunity to come together to learn about all of the amazing efforts that some of the tribal communities are doing to reclaim traditional tobacco, reduce commercial tobacco. Allies are welcome to attend, and it's always just been a really fun event to network and learn and share knowledge. One of the last points I'll make is the artist that I mentioned with the app. She developed the artwork for the conference, so it's exciting to continue to work with her. That's all I have.
Thank you so much, Dana. Let's have some questions, Darren.
Inspiring work. So to connect a couple dots that you talked about, is there any conversation in the Native community about trying to reduce the nicotine in the Nicotiana rustica?
Yeah, that's a really, really good question. So we actually had a small pilot study with Dylan and Coco. Dylan's the tribal councilman I mentioned, or past tribal councilman, and then Coco's at the American Indian Cancer Foundation. And we did this work with Irina Stepanoff, and the idea was to understand through which protocol, is it, drying the tobacco leaves through the air, freezing the tobacco leaves, the different protocols, how that leads to different levels of nicotine, with the concern that if children are handling these, or really anybody, that nicotine exposure on their skin can be harmful. Beyond that, though, I do not know. I think something that would be really, interesting to have that question. And I think maybe what you're getting at is in a lot of ceremony, having access to commercial tobacco in lieu of traditional tobacco. But a lot of communities have been working on that movement for a while and have gotten access to traditional tobacco. Certainly it's not for every community, but.
Dana, I think the piece that you might not have mentioned when you were talking about traditional tobacco is that it's frequently not smoked.
Yep.
And it's not used in the same way that, someone might use commercial tobacco in this sort of
Yeah.
regular, many times a day way,
Yeah.
even when it's smoked.
Yeah, yeah, a lot of the colleagues I call friends will put it out in offering when they say a prayer or to, you know, to have a good day or to bless somebody.
Any other questions?
I just have a quick question about, I guess, your app, your tech-based, like that sort of intervention. You talk a lot about like the social supports and things of that nature and how those are important in that community and many others when you're like doing behavioral change. Is there any sort of inclination of what you could do to add to the app to have like that kind of support integrated in there in the text-based part and that sort of situation?
Yeah, yeah, well, it's funny, every time you use the mic, I think I have to come over there. Yes, so we were working with the infrastructure that we had. And one thing is that there is promotion of a social media site that American Indian Cancer Foundation maintains that creates a community for specifically American Indian people trying to quit smoking. But as we know, that probably still is not enough social support. We know social support and letting your loved ones know and friends that you're trying to quit is huge, and finding that social support. I actually have a colleague in Oklahoma, Ashley Cole, who is interested in looking at providing like virtual social support sessions as part of the app, or something a little more interactive where people can find a place where they feel like they belong and just share their trials and challenges. But it's definitely an area that we're thinking about. It can cost a lot of money to develop an app, as I've learned, and so trying to find ways to like integrate these components in a way that fits into an NIH budget. But you know, we'll figure it out.
Yeah, the work you described is just really exciting and very, very impressive. I was curious about your thoughts about the likelihood of, in terms of on the policy side, those changes. What kind of challenges do you see? And then there are people thinking about strategies to circumvent some uphill battles.
Yes, that is the golden question. So I can draw some speculation to that based on the menthol ban. So while menthol has been banned, as Rachel would know well, in Minneapolis and many local and even states believe, it's still allowed federally at the national level. However, the US has painfully, the government moved forward with a menthol ban. Probably should have been implemented. So why is menthol allowed? When the law went into effect, flavors were banned because we knew that that creates youth appeal and can make it harder to quit. Again, the compromise was to allow menthol to stay on the marketplace, which unfortunately disproportionately is targeted to many Black and African American communities. So there is an evidence base that menthol should be banned. I mean, this has been decades. We know that it causes a cooling cessation. So youth are more likely to initiate, to transition to dependence, and it actually has been shown to make it harder for some populations to quit smoking. And if you've ever smelled it, it smells sweeter. I mean, all these things probably make sense to you. The US has proposed and actually set, you know, all the steps have gone through, but then it's been wrapped up in Congress. We were hoping to see a menthol ban last year, maybe the year before. With the upcoming presidential election, there is less interest in pursuing such a provocative law at this point. So while the nicotine standard, evidence-wise, will be more of a watershed moment, right? Because you're going to impact everybody that uses cigarettes. That policy in itself is still probably a decade or more away. New Zealand was days away from passing a full comprehensive set of policies, including like a smoke-free generation where kids born after 2009 could not purchase. They were going to dramatically reduce the number of retail locations. And then the last was to de-nicotinize cigarettes or reduce. And this was looking great. This was largely led from the Maori. And really from an environmental justice space, from littering. The new government came in and basically appealed everything. And so I've been working with American Indian Cancer Foundation on a commentary that essentially, once again, it was because of the financial goals of the administration, not thinking about those populations who have not been thought about. So unfortunately, decades probably, but
Wasn't there another country that was considering the cohort model? I thought
Singapore.
somebody had passed it.
yep, I think there are multiple countries.
Singapore do a smoke-free generation, which one was it?
I'm not sure.
Singapore that did a smoke-free generation.
Yeah, but that's a really exciting policy as well. We in the United States just passed the tobacco 21, which is important because most people start in their youth, and when you have 18-year-olds that can purchase tobacco in school with 17, 16, 15-year-olds, increasing at 21 is not a silver bullet, but it does increase purchasing. Okay.
Well, we are at 11 o'clock, and thank you so much. I will see all of you next week, I hope.